So, November 5th, we've got two big events coming up. There's the virtual career fair sponsored by the Student Nurse Association, which begins at 12 noon. And then in the early evening, we transfer into the Postcards from Reality event. And obviously, both of these events have traditionally been live events for which we would all travel up to stores. That's not reasonable this year, so they will be virtual. The career fair is the career fair. I don't think I need to explain that to you guys. But Postcards from Reality is a majorly cool event that has two main purposes. And they're sort of equal in terms of importance to you, but the one that really makes a difference for you is when Pam Cartledge comes and explains to you how do you submit an application for the NCLEX exam. And I think we can all agree that's a fairly important next step in your career path. I'm not saying it's tricky or it's hard, but like most things with us, the state, it needs to be done quite specifically and intentionally. We've talked briefly about how you can sit where you physically take the exam makes never mind, because it's the same exam given in all 50 states and a variety of foreign countries as well. But where do you want to get licensed is a bigger question. And the state in which you choose to get licensed by exam is the one that grants you permission. So if you are absolutely dead set on working in California, I say to you from past experience, get licensed in Connecticut and then get licensed in California by endorsement. If you wait for California to give you permission to test for a California license, you're going to be old and gray. I've had students lose jobs because California cannot get their act together. Somebody text Eugene. Oh, never mind. I found it. Never mind. Found it. California takes a really long time to get you permission. So get it in Connecticut and then get your what's it called? License by endorsement there. If you want to be licensed in New York, they move almost as quick as Connecticut, but you need to take, I believe it's 2 short, brief continuing education, additional continuing education classes before they'll give you permission. They're available online. It's not a lot of money. It's kind of easy peasy, but California is a much higher hurdle. Sammy, I'm talking about getting your permission to take your NCLEX exam and how Pam Cartledge explains how to submit the application for NCLEX at Postcards from Reality, which is happening on November 5th. And I am recording.
At 4 o'clock, I'm sorry, on the 5th?
Yeah, if you say so, James.
Oh, no, I'm just asking. I don't know.
I don't know either.
Oh.
I know it's that evening sort of thing. So that's one important aspect of Postcards. The second one is recent alumni will come back and talk about their experience transitioning into the work life of a registered nurse from school to work. And we try to get students from a variety of different backgrounds, different hospitals, different specialties, different types of units, and you can just pop into the rooms. And this is the way it would have gone up in stores. You know, we put the students in, the former students in rooms. And if you were interested in working in the emergency department, you can go talk to whomever was their experience. If you were interested in talking to somebody who's working at Hartford Hospital, you could go talk to somebody from Hartford Hospital. Labor, you know, again, we try to get a variety of specialties and a variety of hospitals so that you can hear those unique transition experiences. It's always been a really fabulous night. So I will look forward to seeing you there. So that's November 5th. So so that's kind of a full day from the career fair through postcards. So we will not have class on November 5th. And that is, I believe, supposed to be our last lecture. And it's still important content that you need to have for the final exam. So we're going to delay the final exam. We will have our final, and I'll send out an email, but just listen for a minute. We're going to not have class on the 5th. We are going to take our last lecture and quiz that should have been done on the 5th, but we're going to do that on November 12th. Then our final exam will be on November 19th. Now on November 19th, we were supposed to do the ATI comprehensive exam. So I will still offer the comprehensive exam on November 19th, but my understanding is you also have your community health presentations that day. So for those of you who do not want to overbook the 19th so that you are both fresh for the final and presentation ready for community health, I will offer at least 2 additional dates for the ATI comprehensive exam that are to be determined at this point in time, so that you will have 3 opportunities to take that exam, 3 choices, I should say, not opportunities, but 3 choices of when to take the comprehensive ATI. I hope you feel that that's the best way for you to be able to give your attention to the career fair as well as postcards, still focus on the last quiz, on the last quiz and the last lecture, be able to take the exam without feeling overloaded, and be able to take ATI without having it squished all into the same day. Again, an email will come out on this, but I just want you to know that there's not going to be a lecture on the 5th. It will be on the 12th, and the final exam is on November 19th. A lot to take in. Probably can't comment now until you really see it laid out, but don't hesitate to get back to me if you've got any concerns, okay? Yeah, I'm going to take that as an okay.
Okay.
I actually have one question.
Of course, go ahead, Tiff.
Oh, well,
So in regards to November 5th, what's
Yeah.
going to happen with research, or are you not really sure about that class?
I'm not really sure about that class.
That's fair.
Okay.
we're not either, so. Oh, sorry.
No, I heard you. Yeah, that's okay. You know, there's one of those commercials where the guy's dancing in his underwear in the kitchen and he's having a fine time. He's got a little rhythm going. And all of a sudden from his laptop, you hear, "We can see you, Peter." I feel like I've had a few been there, done that lately, if you know what I mean.
I have a question.
Yes, ma'am.
Would one of the options to take the ETI predictor be after Thanksgiving break? Or would it all be before?
I'm open to discussion. Because there's, again, most of you will still have clinical that week, which I assume includes community health. Um, and obviously I've got to work around that, hence the multiple options, Robin. But, I also don't want to completely get it backed up against the retake, because unless you get 100%, which, believe me, I will light a number of candles that everybody gets 100%. But since nobody in my realm has ever done that before on the comprehensive, again, one of you will be the first. One of you will be the first. But again, I don't want you to get so backed up that you can't do all the other stuff that comes, Robin. But I'm certainly open to discussion, okay?
Okay, thank you.
No worries. Again, I'm even open to, what do you call it? To scheduling something during, and again, I don't want to take anybody's breakaway, but I am open to doing something, early in that week, perhaps, for people that aren't traveling or just trying to de-escalate and may be able to focus a little bit more once everything else is off the table. Again, in that regard, I'm trying to be a little flexible, since I realize it is a change to the syllabus, which is sort of a big deal, but that's also how important I think it is for you to put your best foot forward at the career fair and enjoy postcards, because postcards should be enjoyed.
Yeah, just trying to have a general idea of like, are we going to have less time to study for it or more time to study for it?
Yeah,
But
I hear you. Yep. And actually, on the career fair note, and again, I absolutely know not everyone wants to work at Yale New Haven. That's not my intention and all, but they tend to be more assertive in looking for opportunities with students. And they have, again, requested to meet with you, the Stanford students, separate from the career fair. So we are looking for some time on a Thursday, not November 5th, but on a Thursday, for you to have a presentation by the Yale New Haven Health System recruitment team. And so that would include all of their hospitals under the corporate umbrella as well. And we're working together to make that happen also. Let's let you see it. Okay. All right, any other questions? Sort of any topics, not just what we discussed, but anything else?
Carolyn, Lucy's in the waiting room.
I let her in, thank you.
Thank you.
I thought about not, but don't tell her I said that.
Very funny.
Oh, shoot, rats. Okay. There being no questions, let's get started on our next lecture. So there is a bit of a review PowerPoint posted. It's mostly anatomy, mostly assessment, a little bit about meninges and meningeal irritation, seizures, things that we've discussed a couple of different times. So in an effort to be efficient with time, I didn't think we needed to review it en masse again. So trying to go with a little bit of newer stuff, or a lot of bit of newer stuff with some review. We know, so we'll start with the spinal cord. We know that the spinal cord's carrying the nerves from the brain all the way down to the farthest peripheral points. The spinal cord is also related or responsible for the different reflexes at different points in the body as well. Trauma to the spinal cord can obviously be exceptionally serious. And while the spinal cord has remarkable ability to regenerate and to heal, it is also possible to do permanent damage to the spinal cord. And where the injury on the spinal cord takes place is of critical note, because that will determine where the functionality is impacted. And again, the higher up on the spinal cord the injury occurs, the more significant the decrease in function. And it doesn't need to be a severing of the cord. Contusions, lacerations, and compression all can result in exactly the same type of dysfunction. And like all areas of the body, blood flow is required to make everything work over time. So again, the level of the injury helps determine what the level of dysfunction might be. The spinal cord is particularly sensitive to falls and other sorts of injuries. And what can happen is, again, the higher the injury, loss of respiratory function, spinal cord shock, which we spoke of at the beginning of the semester, and then a sort of ongoing and recurrent potential problem of autonomic dysreflexia, which we'll talk more about. So this illustration shows you what's impacted in terms of where the injury is. And again, cervical vertebrae 1 and 2 really are impacted when there's the highest level of injury. That's why they call it the hangman's fracture, because that's usually where the injury takes place if a patient has, if an individual has been subjected to hanging. So their ability to breathe, their ability to move anything below the neck can be impaired. And then again, as we move farther down, leg movement, balance, from the point of muscle control, and the work that muscles do to help maintain balance. I'm definitely not talking about cerebellar balance, but how muscles interact, those core muscles. The reason you do Pilates and other core exercises are impacted as muscles become impaired because of spinal cord injuries. You can also have bowel and bladder and sexual function or dysfunction, again, depending on where the injury takes place. What's a synonym for tetraplegia?
Quadriplegia?
Yes. And so they've been trying to move to tetraplegia for a while because tetra is the same root as para. And I can't remember whether it's Latin or Greek, but they're trying to get it from the same root, versus quad and para are different roots. That's my entomology lecture of the day. That's pretty much all I know.
Quadros Latin,
Thank you.
tetra is Greek.
So para must be Greek.
Yep.
Also. Thank you. So again, another little, if you will, this is almost a mnemonic, if you will. Breakfast at 8 controls the 8 cervical vertebrae, and that's the diaphragm, chest wall muscles, arms and shoulders. Lunch at 12, there are 12 thoracic vertebrae. It also impacts the upper body and gastrointestinal function. And then dinner at 5, 5 lumbar and 5 sacral vertebrae, which controls the lower body, bowel, and bladder.
Hey, Carol Ann.
Yes, James.
So when I learned it, I learned that the top three exactly the same, but sacral, we just learned that as dessert.
Ah, there you go. Thank you. Talked about that. So when you're doing an assessment of a patient who is at risk for a spinal cord injury, you're looking for any sort of change in respiratory pattern or depth and ease of breathing, and motor and sensory changes, loss of reflexes, bowel and bladder control, although with bowel and bladder, there are with injuries and trauma, there are other reasons for bowel and bladder control issues as well. And that should be presence of sweat, not swearing. Boy, is that Freudian for me, huh? It's presence of sweat, which does not occur in paralyzed areas, which I always found sort of interesting, which is why I included it. Unbelievable. Why do you think injuries to the upper cervical vertebrae is usually fatal?
Can't breathe.
Can't breathe. So you literally, your time for rescue is quite minimal. You know, again, if at 4 minutes you start having brain damage and there's a trauma, if it takes more than 4 minutes to get somebody out of the situation to a point of safety, immobilize them so that you don't cause further damage. And all of you EMTs and paramedics would know this even better than I, working out in the field. Again, you don't just pull somebody out when you suspect spinal cord injury. One tries to immobilize them so that you can minimize the further damage as you do try to move them to a point of safety where you can do assessment. And again, C4 is where the innervation to the phrenic nerve, which in the phrenic nerve is what motivates the diaphragm. And then thoracic level injuries, again, movement of the lower extremities, as well as bowel and bladder control is impacted. And then with injuries above thoracic level 6, you get this autonomic dysreflexia. And autonomic dysreflexia is where there's typically what happens is there's something, so it's the nerves below the injury still have sensation. So they try to send a message up to the brain. Oh, I'm itchy. Oh, something hurts. Oh, something's hot. They try to let the brain know something's going on, as usually happens, but the message doesn't get up to the brain. It's been, the communication pathway has been severed. So the nerves try harder. Okay, you're not going to listen to me? Well, I'll make it even more significant a message. Maybe I'll make you start sweating. Maybe I'll slow the heart down. Maybe I'll drop your blood pressure. You can have goosebumps on all these areas. And this is a way for essentially the nervous system to let the brain know something bad is happening. And it just gets worse when the brain can't respond, or the pain is not relieved, or the bladder is not relieved. So for folks who've had spinal cord injuries in the thoracic level, and whether the bladder is full, they're constipated, something is too tight or causing pain, and the autonomic dysreflexia, particularly related to the response of hypotension and bradycardia, can be life-threatening. So you need to be aware of this number one possibility. You need to teach a patient how to be aware of this eventuality and how to resolve it. So you need to loosen the belt buckle. You need to make sure there's no injury on the feet if they're wearing shoes or something. You need to empty the bladder. You need to evacuate the bowel as necessary. But you need to be aware that autonomic dysreflexia can be life-threatening to a patient. And again, lumbar and sacral areas, again, loss of movement and sensation in the lower extremities, a neurogenic bladder where it won't, the urine will not come out on its own. Patients typically require intermittent catheterization. Sexual dysfunction needs to be evaluated. Again, that tends to be, you have to, a lower injury still allows for sexual function, particularly in men. And in fact, in spinal cord injury, an erection can be a sign of spinal cord injury, and having to evaluate for further injury. Did I ever tell you guys, this is one of my funny stories that ended up okay, could have ended up elsewhere. Did I ever tell you about the guy who came in without any identification? He had been in a really significant motor vehicle crash one Saturday, and he came in unidentified. He didn't have any identification on him. And I was charge nurse in the ED, and I feel a real significant responsibility when we had unidentified patients come in, because there's somebody's people. Somebody needs to be with them. Somebody needs to know something has happened to them and be there with them. So the state police came, this guy came into the trauma room, the trauma team worked on him, and I know he got whisked to the OR relatively quickly. I was working with the state police, who brought me whatever they had. There was no wallet in the car, but there was a car registration. The car was registered to a woman. I saw that much as he went into the trauma room, that it wasn't a woman. But I started by trying to locate that gal to see if she knew whose car it was. Maybe it was her husband, her boyfriend, something like that. So I call her, and she loaned her car to one of her female friends. So she had to call the female friend to find out who the car was with. That gal called me. She had loaned the car to somebody else. I'm sitting there thinking, I'm glad these are not my friends. When I loan a car out, I kind of expect it to stay around. But I continued working. So she's on the phone. I'm talking like the third or fourth person, who says, well, did the guy have red hair? And she was asking me. And so the nurse who had been in the trauma room was sitting next to me finishing his notes. And I said, Brian, did the guy have red hair? And Brian goes, I don't know. Okay, well, we're not exactly sure. He really didn't spend a lot of time here. Is there anything else I done? So she goes, did he have a beard? It's kind of a blondish beard. Go to Brian. Brian, you guy have a beard? I don't know. So she asked me 2 or 3 more questions about tattoos and stuff. It was pretty specific stuff. And Brian's answer to everything was, gee, I don't know. I finally said to the woman, can you hold on a minute? Brian, Were you in the room? Did you work with the patient? What the hell were you doing in there? Is there anything you can give me? She goes, I'm telling you, Carol Ann, all we could talk about was, she proceeded to say something. He proceeded to say something. And I'm like, that he was basically the best endowed man that anybody had ever seen. And he had the absolutely hugest erection anybody in the trauma room had ever seen. And I go, how am I supposed to use that? So I go back to the woman and said, I'm sorry, you know, it really was a very chaotic scene. Guy was injured quite badly and went to the OR. And she goes, well, I'm going to try just one more thing. She basically asked me, did he have a large penis? And I go, well, as a matter of fact, he did. She goes, I know exactly who it is. And within about an hour, he had family there. So we actually identified a guy by the size of his penis. And he did have a spinal cord injury. But so that's my funny story for the day, if you will.
That's hilarious.
Yeah.
Yeah.
We had identical twins come in one day, and we couldn't tell them apart. They were from the Coast Guard Academy, and apparently back then they were not supposed to have tattoo. If you came in with a tattoo, it was one thing, but you were not supposed to get tattoos. One of the brothers had gotten a tattoo, and that was the only way that their friends could tell them apart. It was on their back sides. And when their mother came in and found out that one of them had gotten a tattoo, she goes, if he lives through this, I'll kill him. So that it was, again, we knew who they were. We just didn't know which twin was which, because they really were identical, except by the tattoos on their ass. You know, the emergency department is a fascinating place to work for a variety of reasons. Not only clinically, but get the best stories for sure. All right, so again, as I said, we really work to immobilize patients so that we don't do further damage. Now, I will say that's become a bit of an evolving science, and this should be somewhat embarrassing. And again, for you folks working out as first responders, jump in here, please. But in the olden days, everyone got a C-collar, which was a stiff, hard collar that kept their head and their shoulders aligned to prevent further neck damage. And then they were put on a hard backboard, placed on a stretcher, and wheeled into the ED. What we found was that EDs were so bloody slow at assessing and clearing C-spines so that patients could come off the backboard. They were actually developing pressure sores from the hours that they were spending in the ED. And so the use of backboards has declined. They're still used to move patients onto stretchers, things like that, if there is a sign of weakness. But my understanding is out in the field, they'll put a C-spine collar on, and a patient who is in control, moving all fours, can sit up on a stretcher. James, Anna, I know a couple of you other, what's your experience with potential spinal cord injuries out in the field?
On my floor, they use the C collars on patients who have like a fall until they can rule out spinal injury, and then after they've ruled out that there's no like damage to the spine, then they take the collars off.
Yep.
But it looks really uncomfortable for them.
Those C collars are, I bet you they are uncomfortable, Jack, don't you think? I mean, they really do to sort of extend the neck, and they keep it aligned. It's got very important purpose, trying to save functionality and all, but I'm sure it's not comfortable by any stretch of the imagination. If you do have a patient with a spinal cord injury, you want to keep them aligned. You want to keep them not only comfortable because it's the right thing to do, but you don't want them moving and thrashing about on their own. You're going to log roll these patients. Again, if you have somebody with a suspected, particularly cervical spine injury, usually there is somebody at the head of the bed who's in charge of maintaining the head. And you will literally put your hands on their shoulders, cradling their head so that as they're rolled, you're keeping them aligned. And it becomes a multi-person job. It's not just sort of slinging their leg over and turning them to the other side, if you will. So keeping that alignment, keeping them immobilized, log rolling them doesn't mean they don't get turned. Again, you still need to turn them and get them off their back and things like that. But maintaining alignment is sort of key. We talked about spinal shock with, again, decreased reflexes, decreased sensation. And so spinal shock is where there may not have been a full injury to the spinal cord, but a contusion, bruise, if you will, needs to resolve. And one of the issues or one of the concerns is if the inflammation at the sign of the injury is too significant or becomes too great, you can cause spinal cord compression, which decreases blood flow below the injury, which can create, just like an embolic stroke up above, you can decrease the blood flow to the spinal cord by that compression and end up with damage below that point. So again, this is why repeated careful assessment is so important. You need to make sure they're maintaining their function. You need to be able to show, God willing, an improvement over time, but you certainly want to be hyper aware of potential decline in functionality also, which may be related to increasing inflammation, hemorrhage, things like that, which are going to cause further long-term damage. I should say it wasn't spinal shock, but neurogenic shock that we spoke of at the beginning of the semester. And again, normally, what we typically see when heart rate goes up, oftentimes blood pressure will go down, or if blood pressure goes up, heart rate might go down. With neurogenic shock, both blood pressure and heart rate go down. That's a problem. You get this peripheral vasodilation, venous pooling. This is what's causing the hypotension. It results in a decreased cardiac output, and this is most common in injuries above the sixth thoracic vertebrae. And again, autonomic dysreflexia, something is annoying the nerves and it's not getting the response it expects from the brain. So again, think of it, the bladder's full, it knows it needs to be emptied, the nerves are sending that signal up to the brain, yo, we need to go to the bathroom here, and nothing's happening. So it doubles down and makes it even more insistent that something needs to be done. And again, hypertension, headache, diaphoresis, bradycardia. Let's see if we can get this YouTube going. I know I need to switch the screen share. Oh, come on, this worked yesterday. Why you do this to me? I'll find you another one, sorry. All right. But again, autonomic dysreflexia can be life-threatening to your patients. Again, besides the hypertension, they could feel restless, anxiety, nauseous. So you want to try to relieve the whatever is annoying the nerves. Empty the bladder, empty the bowel, remove the pain. Something's too tight, whether it's be the shoes are laced too tight, maybe there's a wound on the, look for a blister on the feet, loosen the belt buckle, loosen the waist of clothes, things like that. And we need to not only teach the patient, but we need to teach the family as well what those signs and symptoms are and how important it is to act on them. Higher level injuries can impair respiratory muscles, which we've spoken of. Even folks with upper thoracic injuries, lower cervical injuries, they can have a weakness in the nerve response so that their respiratory response is not going to be as deep and robust. So they may be able, let's say when they're awake, they can breathe on their own and respond and alter their respiratory pattern as needed. But when they're falling asleep, maybe they need mechanical support, whether it be CPAP or a trach with mechanical ventilation for while they're sleeping. But we need to encourage deep breathing and coughing. We need to watch their blood gases to make sure there is really good both respiration and ventilation. Cardiac dysrhythmias are possible with spinal cord injuries as well. Again, we're looking for hemorrhages and bleeding in trauma, which can also impact the cardiovascular signs. Folks who have had spinal cord injuries are, by sort of definition, going to have decreased mobility. So we need to be hyper alert for DVTs and things like that. And we need to be aggressive about mobilizing patients, whether it's out of bed, passive range of motion for these patients, wearing anti-embolism stockings, doing physical therapy to strengthen the muscles that they can still work, but also, again, to assist with the passive range of motion of the limbs that are weak or not moving on their own. When patients sit up, they are at greater risk for orthostatic hypotension. Again, they're not getting that muscle contraction to move venous return and things like that. And so there's a lot more blood pooling in, sort of your lower areas related to lack of muscle contraction and all the things that help venous return. So we're assessing the neuro status. You need to assess musculoskeletal status, movement and strength in all extremities. And I want to go back to passive range of motion for a moment. Again, we're talking all joints, all our extremities. Right down to our fingers. We should be putting their hands into fists and straightening them out, spreading the fingers. Same with the toes, sort of thing. We really don't want any joints to suffer from disuse. And again, monitoring for signs of both shock and autonomic dysreflexia. In some respects regarding pain, the assessment of pain can be more complicated because they're not going to feel pain below a level of the injury, if you will. So again, pain is sort of the body's way of letting you know something's wrong, something's going on, and they're not going to be able to recognize those different signs. So, but over time, I think it's fair to say they do figure out how their body is going to talk to them moving forward. I've worked very closely with 2 paraplegics in my life, and they're very good over time about knowing that something's not right. They can't necessarily define it. They can't necessarily pinpoint what the issue is. But, I think of my cousin who, after a spinal cord stroke 8 years ago, he gets a tightening right at the level of where his pelagia starts. So he'll say, my stomach's getting tight. It's not that he's nauseous. It's not that he's got pain. He feels like he's pulled a muscle. And that's his body's way of knowing something's not right below his level of injury. He's found kidney stones. He's found urinary tract infections. He had appendicitis. And again, goes, my stomach is tight. None of those things are the signs and symptoms that somebody who had full range of motion and full sensation would necessarily describe for kidney stone, UTI, or appendicitis. But that's, again, his body's way of telling him something's going on below the level of his injury. We're going to assess the GI tract. We're going to, again, check for distension. We're going to be keeping our eyes open, listening, or our eyes open, listening. Maybe we'll keep our ears open, listening for bowel sounds. Again, without the extra movement, we know how movement and mobility is a benefit to the GI tract. Patients don't always have that. Same level of mobility, so they need a bowel program. We need to prevent constipation, and it begins with the basics. They need a balanced diet that's high in fiber, and they need to stay hydrated. Start with the basics. Then we can add either medications or a bowel evacuation program. If they're not able to empty their bladder spontaneously, then intermittent catheterization is necessary. And we can teach patients how to do that. Female and male. I've actually not been part of that program with bladder training or self-catheterization. I've always sort of wondered, and I'm sure I can go on YouTube and see how does a woman catheterize herself, because I think that requires a fair bit of mobility to make that happen. But again, that it's done all the time, very successfully, and teaching them how to do it in a safe manner so that they're not introducing infection into their body is a big deal. People with paraplegia and quadriplegia, for that matter, also are more prone to renal calculi, aka kidney stones. Why do you think that is? Why are patients with plegia more prone to kidney stones?
More calcium in the blood because of their immobility.
Right. They're also prone to osteoporosis. Again, they don't have the ability to do a lot of weight training, what's that called? Weight-based exercises. That's not the right phraseology.
Weight bearing.
And so they get loss of calcium out of the bones and leads to renal calculi.
It's weight bearing, I believe.
Weight bearing, that's it. Thank you, Eugene. I appreciate that. God, thank God you guys are here. And from a psychological perspective, it's fair to say that these are life-altering injuries. And so the anxiety, the depression, the changes to functionality are significant. So we need to be able to support these folks and put them in contact with, whether it's social work support, psychotherapy support, and other community resources that help them maintain their psychosocial balance and also get them the help they may need as they're reintroduced back into their lives and for what they may need help with. And then skin integrity. Again, these patients, particularly those in wheelchairs, the quadriplegics tend to get very high-tech chairs that are really custom built and custom fitted for them because they are not able to shift their weight on their own. They need to be positioned in a way that they are absolutely not putting additional pressure on their bony prominences and all those areas that we know are at risk for pressure wounds. Paraplegic clients need to be taught to weight shift on a regular basis. They can't sit in the same position hour after hour after hour. So whether they're going to do arm raises on their chair, whether they shift right cheek for a while, left cheek for a while, move from their wheelchair to a different, whether it's back to bed or a different chair, which takes tremendous amount of energy and upper body strength, to say the least. But we need to be hyper vigilant about skin integrity and make sure they understand they need to reposition themselves one way or another every 2 hours, just like we do for every other patient over time. So, why don't we take a 10-minute break? I know it's early, but everybody come back at 10:25 and we'll get started on our new topics moving forward. Any questions on spinal cord injuries?
No. Don't forget to turn off the recording, I guess.
Oh, thank you, sir. I appreciate that. And remind me when we come back. Okay. Are we ready to go? What time did I say come back?
25.
All right. Sorry about that. Thanks. All right. So now we're going to talk about multiple sclerosis.
Did you want to go over the midterm first, I think you said?
Oh, you're right. I did. Okay. So next week is the midterm.
Also recording, Carol-Ann, but I don't know if you want to do that after.
I am. Yes. Thank you. It's a 75 question exam, and it'll be on our first 3 lectures plus today. Today's lecture will have twice as many questions as the first 3. So let's see. So there'll probably be about 15 questions per lecture, 1, 2, and 3, and closer to 30 for this lecture. I'll send out a blueprint as soon as possible, and we'll do a review going to try to target Sunday evening. And of course, it'll be recorded. And if anybody has more questions or needs more time, just ask me and we'll put something together. So 75 questions, lectures 1 through 4, blueprint coming, and we'll do a review probably Sunday evening. That's a little early, but I know once we get to Monday, Tuesday, and Wednesday, clinical gets hot and heavy. So the review might be Monday evening. I really have to see how the test comes together and what the blueprint looks like, okay?
Yep.
Any questions about that?
Just the sooner the better on the review, just so we could, target ourselves.
Yep, I understand. All right, multiple sclerosis. So again, it's a chronic, progressive, degenerative neuro disease. And it's characterized by the demyelination of the neuron sheath. And I really couldn't spell this week, could I? In the brain and the spinal cord. It responds to certain autoimmune or immunology support therapies, but there is also some thought that it may be viral in nature, or a virus might be a trigger of some sort. Most typically diagnosed between the ages of 20 and 40. And it's one of those diagnoses that is that has area of periods of exacerbation along with remissions. And so hopefully when there is an exacerbation, to try to get a patient as close to their previous baseline as possible, and to not have overly progressive slides in their abilities. There are, one of the diagnostic tests is a lumbar puncture, and you're looking for increased gamma globulin levels in the CSF, while the serum globulin levels are normal. But they're also going to see abnormal EEG findings. It is, some 250,000, 300,000 people have multiple sclerosis any given year. The later the onset, typically the more rapid the decline or progression of the disease. So while being diagnosed early certainly seems tragic unto itself, being diagnosed later doesn't necessarily change your time frame in terms of life expectancy. The later you're diagnosed, the more significant the progression of the disease, the speed with which the disease progresses is significant. It often starts with cranial nerve deficits, optic neuritis. There may be a change in someone's vision, which brings them to their doctor. Over time, there's, again, decreased strength in the muscles and muscle tone. There is some ataxia. And what is ataxia?
Poor coordination of movements.
Right, poor coordination, movements, they look sort of discoordinated, like not all the limbs are dancing to the same song, if you will. There is also this Lermitz sign, which creates sort of a spinal sensation, electrical sensation down the back of the legs when they flex their neck. Could be both arms, could be one arm, but again, patients will speak of this feeling of a tingling or a electrical sensation down the back of their legs, arms, when they flex their neck. This illustration from the Multiple Sclerosis Society, it looks like there are a couple of things working in tandem. Someone needs to have a genetic predisposition to MS, and then an environmental trigger exacerbates that genetic predisposition. There's an immune attack, an autoimmune response, and that's what's causing the loss of myelin and nerve fibers over time. Let you guys watch these. I did post a couple of other YouTubes in Husky CT that might be helpful for you as well. So again, an illustration here of initially a relatively healthy myelinated nerve fiber. That myelin is, if you will, the protective coating over each nerve. Over time, that myelin becomes damaged, injured, and disappears. And then again, over time, those nerves literally shrink, and the connection between each of the nerves, which is supposed to be sort of a long, if not continuous, but a contiguous, if you will, system, falls apart, creating weakness, loss of movement, discoordination, and other signs and symptoms. And some of those findings include fatigue and weakness, that discoordination of ataxia, balance issues of vertigo, tremors, spasticity, particularly of the lower extremities, again, blurred vision, dysphagia, decreased and abnormal reflexes, emotional lability, bowel and bladder changes. As the nerves become less functional, they have decreased perception of pain, pressure, and temperature. So significant alterations to nerve function and neurological function. What we need to help patients do and to keep, number one is keep them as healthy as possible, keep them as strong as possible, keep them in remissions as long as possible. And it's pretty clear that fatigue and stress and other common illnesses are really harmful to folks with MS. So keeping them healthy, learning to keep themselves rested, get adequate sleep at night, rest during the day as necessary is really important. Mitigate stress in as many ways as possible, whether they be, get into meditation, whether appropriate supportive exercise, whatever they need to do, again, to mitigate stress in their lives. We need to keep them healthy, keep them safe, I mean to say. So as they get increased weak, have issues with balance, issues with vision, we need to make sure their homes are safe, that they can maintain their balance. We need to encourage them to use ambulatory aids if necessary, which for many people is a very difficult accommodation to make. We need to keep them, their bowels working, keep them from getting constipated. And while we're doing all this, we want them to be as independent as possible, yet being as safe as possible and maintaining a good, healthy regime in general. Regular exercise, regular physical therapy is necessary. Speech and occupational therapy for fine motor movements, and also to support strong swallowing, gag reflex might be necessary also. And then again, community-based support groups. And I have to say again that many folks will say that's not their thing. And then when they do give it a try, they're often quite surprised at how much support, how much comfort, and how much they learn from these organizations. So one of the things about MS is it's very difficult to determine a prognosis. About a third of the patients, as it says here, a mild course, moderate course, and a third will become significantly disabled. Some instances of better outcomes are women tend to do better if their onset of symptoms is before the age of 35. They tend to do better in the long term. Those that have different sensory symptoms actually tend to do better. And if they're able to recover to their baseline with a relapse, that also tends to show they'll have a long-term, a better outcome. With relapses, they're often treated with prednisones, high-dose steroids, physical therapy, psychosocial support. Keep them safe during their exacerbations or relapses. And again, other medications that support the immune system are being developed on a pretty regular basis with MS. And from my experience, some of these medications and therapists help some patients and others help other patients. So knowing exactly which medication is going to be a key for any one client takes a little bit of detective work and I hate to say trial and error, but again, no one medicine seems to be perfect for everybody. Really need to figure out what's going to work best for each patient. And again, here are some of the different symptoms that come with multiple sclerosis. Fatigue can be treated with some different medications, amantadine, SSRIs like fluoxetine, other CNS stimulants, modafinil. Modafinil is also used for folks with narcolepsy. We know the fluoxetine is an antidepressant. And again, with fatigue, patients need to, and when I say accept their limitations, they need to get good sleep at night. They need to have a healthy sleep hygiene regime. They need to commit to X number of hours of sleep per night. Pushing through fatigue with MS tends to be more harmful than helpful. So if they need to take a break, if they need to take a rest during the day, that is only going to help them in the long run. Pain, again, when we're talking about neurological pain, often patients do better with medications like gabapentin. You see that as a sort of first line medication for neurogenic pain versus, your opioids and other Schedule II medications. So again, help them figure out what the appropriate dosage is and see if they can get some help through those sorts of medications. Bladder dysfunction, we can use anticholinergic, antispasmodic medications. Bowel dysfunction, we certainly have studied different bowel regimes on a regular basis. We have so many patients that we're trying to keep regular, and these are, in that category, and there's nothing different about their bowel regimes also. Another neurologic disorder that you'll see is myasthenia gravis. This is another autoimmune neuromuscular disease. This comes from weakness and fatigue of voluntary muscles. And again, it's usually an EEG and muscle innervations, nerve innervation studies are used to diagnose myasthenia gravis. This is caused by insufficient acetylcholine and excessive secretion of cholinesterases, and the muscles are unresponsive to the acetylcholine. These folks can often be, what they may notice first is this droopy eye situation here. Usually not both, although it could happen, but all of a sudden they'll have a one eye droop. You don't get the same sort of whole side of the face droop the way you do with either stroke or Bell's palsy, but they'll often be worked up for both of those also once you see the droopy eye, because you need to be thorough for sure. And so again, not enough acetylcholine, and what there is not, the nerves are not responding to, which leads to muscle weakness and significant fatigue. Women tend to be diagnosed earlier in their 20s and 30s. Men will be diagnosed later in their 60s, but again, that's not hard and fast for everyone. Certainly there have been women diagnosed later in their life as well. Muscle weakness. On that list, what's that droopy eye? Oh, it's right there. Ptosis is the drooping of the eyelids. Eye movement is altered as well. That's the ocular palsy. Your deep tendon reflexes are normal. Sensation is normal, but a change in voice tenor, a hoarseness of voice, also comes along as with the initial symptomology. Oftentimes the muscle weakness and fatigue will get better with rest. They may have trouble chewing or swallowing. And again, you're going to see the eye drooping or ptosis, but reflexes and sensations remain normal. Difficulty with diminished breath sounds because of that sort of decreased respiratory effort, if you will. And so respiratory failure is a potential with these folks. So you need to do a careful respiratory assessment also. In terms of lab work, a serum acetylcholine receptor antibodies, tensilon tests, and so these are not necessarily lab tests that are run on a regular basis. When you see these tests being done, you're tending to look for something specific, trying to rule out a specific diagnosis. A thymectomy, because of its impact on anticholinesterase in the body, can be helpful. And then other anticholinesterase drugs like neostigmine and pyridostigmine can be helpful also. So Tensilon tests, Tensilon is a medication. And we talked about it briefly when we were talking about cholinergic crises, back when we were talking about last semester about Addison's and Cushing's disease. And so how do you differentiate between a myasthenia gravis crisis and a cholinergic crisis? When they have Tensilon administered, if their muscles get stronger, that's someone who's having a myasthenia crisis. When you're doing a Tensilon test, you always want to make sure patients on a cardiac monitor and have your emergency equipment nearby, because Tensilon does put the patient at risk for cardiac arrest via ventricular fibrillation. So again, you administer the Tensilon, they get stronger. That's a myasthenia crisis. Another acute treatment of a crisis is plasmapheresis and IVIG, something that's going to support the immune system. And again, careful respiratory assessment to make sure that there's not progressive respiratory failure. Folks may often need, the mechanical ventilation and an artificial airway with mechanical ventilation. So not only are you doing thorough neuro assessments, but you're doing regular respiratory assessments as well. They've got to be able to maintain deep breathing, coughing. Need to do your swallow surveys to make sure it's safe for them to eat by mouth. Regularly assess muscle strength of all your limbs. Watch for further crisis. Administer your medications. And again, mitigate stress and fatigue and avoid infection, which just creates sort of a physiologic stress in the body. So myasthenia crisis is an extreme exacerbation of the disease, and it's increased pulse, respirations, and blood pressure. Folks are very dyspneic, hypoxic, cyanotic. They can be incontinent of bowel and bladder, decreased absent swallow, cough reflex. And so we're going to add anticholinesterase medications along with the plasmapheresis, the IVIG, at these points in time. On the other hand, a cholinergic crisis is usually caused by over-medication of the anticholinesterase drugs. These folks come in with abdominal cramps, nausea, vomiting, diarrhea, blurred vision, they're pale, hypotensive, decreased pupil movement. And so atropine is an antidote to an overdose of an anticholinesterase drug. So, but again, you need to, so there are certain similarities between a myasthenia gravis crisis and a cholinergic crisis, and the tensilon test is used to determine which is going on. I didn't ask with the MS, but I'll ask now. Has anybody got anyone in their life with MS or myasthenia gravis? Has anybody worked with a patient with MS or MG?
My patient yesterday actually had MS.
Oh yeah? You want to talk a little bit about him, Jonathan, please?
Yeah, he was a 51-year-old male. Um, he he was very weak, and I think his baseline was already quite weak because he had like a wheelchair, and he couldn't even really move his arms.
Oh.
He was on a bunch of meds like baclofen, memantine, amantadine, Effexor, so a lot of what you mentioned.
Mm-hmm.
And yeah, his speech was kind of difficult to understand as well.
Yeah. And what was he admitted for, Jonathan?
Well, he had been admitted on Tuesday with a UTI discharged, but then had to come back because they found positive blood cultures. So he was being treated for bacteremia.
Okay. Yeah, so, and again, whether his UTI was caused, does he catheterize himself normally? How does he usually evacuate his bladder?
He's still able, he's able to pee. He's incontinent, but he's just had a Texas cath.
Uh-huh.
He also had a stage 3 pressure ulcer on his heel, which I assume is from the decreased sensation.
Yep.
But yeah.
Well,
he has chronic UTIs as well.
So again, that's somebody that you really don't want to get into a routine of cathing if they're already plagued by chronic UTIs, And at 50, as a guy, he's going to start, I'm sure they've done a prostate assessment to see if that's creating further complications, because he's of an age where that's a potentiality also. Myasthenia gravis is less common than MS, but you will still run into patients with that diagnosis as well. And then, so now we're going to move on to Parkinson's disease. And again, this is a much more commonly found in the population diagnosis. Your chances of being diagnosed with Parkinson's increases with age. And while some folks can be diagnosed much younger, but almost 2% of the population over the age of 60 have a Parkinson's diagnosis. It's more common in men. And with Parkinson's, 80 clients have lost their dopamine producing cells. Almost 80% of those cells have been lost by the time their symptoms begin to appear. So again, another sign of sort of the redundancy built into the way the body functions, that you have to have significant decrease in functionality before symptoms even begin to show. Another chronic degenerative neurological disorder. There is no test or biomarker for Parkinson's disease. Many people, in terms of how many actually have it, but it's estimated about 1 million people in the United States and about 5 million people around the world have the diagnosis of Parkinson's. So folks with Parkinson's have a fairly distinct walk and posture. It's characterized by a real muscular rigidity, and they're very slow moving. Many folks think of the tremors that come with Parkinson's disease, which are also notable for sure. And again, these are all signs of decreased dopamine within the body. So dopamine is a neurotransmitter that helps regulate movement, emotions, and feelings of pleasure. So if you have decreased dopamine, that means you'll have increasing problems moving, you have trouble modulating your emotions, and decreased feelings of pleasure, happiness, if you will. And again, with Parkinson's, the brain cells that make dopamine are dying. So your particularly dysfunction of the extrapyramidal system is impacted. This can be either slowly progressive, but again, the speed with which it moves is quite unique to each individual. And along with the physical deterioration does come some mental deterioration, although that is usually later in the diagnosis. So the extrapyramidal, I can't say that word, you guys, I'm really sorry. The extrapyramidal system is what starts you moving and helps you complete moving. And so it's sort of it's at the beginning, the end, and helps keep the movement smooth, if you will. So when you impact that, getting started is difficult. Knowing once you do get started, stopping is difficult. And as I said, someone with Parkinson's, their posture and their rigidity and their stride is quite distinctive once you figure out what you're looking for. One of the things that's most common in someone over time with Parkinson's disease is their face becomes almost mask-like. You know, their ability to show happiness, sadness, all of those emotions almost goes away, and the face just doesn't, you know, you can say move or contort the way it used to. Speech becomes increasingly difficult. They've got this slightly forward posture. They short shuffling movement. Again, trouble getting going, trouble stopping sometimes. They bradykinesia, that's where they don't blink, they don't swing their arms with their strides. It is almost a robotic movement in some respects. This is another depiction. So again, blank expressions, that decrease of arm movement and blinking and all those sort of extra movements that just seem to happen, if you will. And with the tremor, while there can be the full tremor of the hands or the arms, what they call is pill rolling. You'll see their fingers and their thumbs sort of constantly rolling something. And so that, along with the other sorts of tremors that they can have. So we're looking for slow movements without that sort of free and easy movement that comes with walking. Monotone speech, akinesis. Again, once they stop, it's difficult to get going again. Once they're going, it's difficult to stop. It's there, and get again, just movement in general is difficult. Handwriting gets smaller over time. The jerking movements of the tremors of the hand, the pill rolling of the fingers, blank facial expressions, difficulty swallowing, speaking, and increased problems with coordination are significant with Parkinson's disease. So no cure for Parkinson's. There are a variety of medications. What's one of the medications most common for Parkinson's?
Levodopa.
Levodopa. Sinemet would be its brand name, if you will. And then there are some folks who've had phenomenal experiences with implanted devices implanted in the brain. Right now, I can't remember. What the hell is it called? Has anyone had experience with patients with Parkinson's disease?
Yeah, I had it
I
my
did.
first semester. Well, go ahead, Kate.
No, you go. You go.
So this guy had Parkinson's for quite some time, and he was in his 80s, as I recall.
Mm-hmm.
And just the basic stuff for him was very difficult to do. Even just getting out of bed was difficult to do, and his hands were tremoring, his shaking. He felt bad about it from a psychological standpoint, but he also was resigned to the fact that there's really not much he could do. His son would come and visit, and he was very supportive, but you could just see family members. It was very hard on them.
It's another one of those things that sort of makes it very difficult to be independent, to live on your own. And so I'm sure it's very scary for folks who, again, as I always say, have been used to managing their lives independently without any problem, right? And now all of a sudden, or over time, increasing problems make it difficult for them to be safe and to do what they want when they want to do. It's tough. Katie, what were you going to say?
I took care of a guy in the spring who he was like in denial. He was like, no, my doctor said I don't have it. But like he did. He had the shuffling gait. He had to straight cath himself 3 times a day. He had the tremors. He had it. He was in just total denial, but it was just a classic case of Parkinson's.
How old was he, Katie?
Older, like in his probably later 60s, early 70s.
Hey, listen,
not terribly old.
I was just going to say that's getting younger every day. Trust me on that.
Yeah, this is true.
But it becomes very becomes overwhelming, diagnoses like this. The other thing that can come with Parkinson's are hallucinations and some psychosis, which can be very significant. So they get impulse control issues, and these may be people who had no issues with impulse control in the past, and all of a sudden really develop significant issues, as it says here, whether it's gambling, hypersexuality, shopping, things like that. So just at a point in time where physically you're being challenged, other stresses and strains on your resources, again, because of health problems, can manifest itself as well. So it can be a real challenge for these folks. I mean, I have to think that hallucinations and psychosis, again, whether they're hearing voices, seeing people, or seeing things, whatever the case may be, it's, again, got to be awfully frightening over time and in terms of how to manage that sort of thing. So the dopamine and the dopamine agonists are the 2 most common medications for treating Parkinson's disease. The levodopa is more common and tends to have slightly better effect. But there are side effects for many of these medications. And I think it's fair to say this is an area where there is tremendous research focused on it over time. I'm trying to think, I'm sorry, as I said, there was a student last year whose uncle had one of the implantable devices, and it's essentially an, I think it's a neurostimulator, and it's implanted in the brain. And they had to fight tooth and nail with their insurance company to get approval for it because the research is not crystal clear that it's a benefit for folks. But the doctor really felt that the patient would do well with it. They fought, they got approval, and it was a lifesaver for this patient. The student talked about how her uncle was able to go back to work. He runs a restaurant and was doing phenomenally well with it. And so there, again, what's the best way to treat somebody? Who knows? But a combination of between knowledge and specialists and advocating, you can end up in a better place in the long run. Again, levodopa, and when we combine it with carbidopa, that's what the Sinemet is. And again, this is the most common medication for patients with Parkinson's disease. Comes with a fair number of side effects, GI distress, potential hypotension, postural hypotension as well. So you make slow dosage adjustments and tend to take the medication with food, can help mitigate some of those side effects with those medications. It has been linked to depression, and sometimes the impact of the medication decreases over time. And then another one of the side effects is this tardive dyskinesia, where patients, they get I call it frog tongue, but they just get these mouth movements and sticking their tongue out, and they're involuntary movements, but they can be significant. So we need to be aware of and assess for these side effects with these medications. Another class of medications are the dopamine receptor agonists. These act as like naturally occurring dopamine would, and they stimulate those receptors directly. They don't work as effectively as the levodopa, but they work for long periods of time for patients who it helps. And here's a list of the dopamine agonists that you see out on the market. Again, hypotension and hallucinations are some of the key side effects. Amantadine helps reducing the dyskinesia. Anticholinergics can help decrease tremors and other stiffness, but can cause constipation. And so because Parkinson's is managed with multiple medications, assessing for the side effects is really important. Some of these are, you need to wean patients off the medications rather than stopping them abruptly. But they can be used for longer terms. Need to teach patients how to sit up, stand up safely, how to sort of combat orthostatic hypotension, help them stay hydrated, again, to help combat the hypotension and not to abruptly discontinue the Sinemet therapy. That can cause a rebound of the symptoms. Some of these meds change the color of urine or perspiration. They need to avoid foods in vitamin B6. It decreases the effectiveness of the dopamine replacements. When you take levodopa with MAO inhibitors, you can end up with hypertensive crisis. So when you're adding an MAO inhibitor, you need to add that slowly and monitor blood pressure over time. So for any patient with mobility issues or weakness, we need to make sure their environment is safe and that they're able to keep themselves safe. Need to offer ambulatory aids as necessary. We need to make sure their gag and swallow reflex are intact. If they start reporting coughing while they're eating, or their family reporting coughing while they're eating, they need another assessment of that. You can certainly work with speech therapy and OT to help mitigate some of those issues, at least early on. Encourage exercise regime, encourage physical therapy. Again, avoid foods high in vitamin B6 with anti-Parkinsonian medications, and how they need to be, how they need to manage their medication regime so that they're consistent and timely, to avoid running out of medications, and how important that is. Keep them healthy so that there aren't other physiologic stresses. And again, always encouraging independence as much as possible. All right, so now we're going to talk about ALS.
If there's a video, it's not on our screen right now.
I'm sorry, John, what was that?
I don't see a video on the screen.
All right, I thank you very much. I'd like to hope fix that. I'm optimistic about the future. Better?
Yep, we see something.
Excellent.
Millions of homes, a man loved a woman, a child it was born. It learned how to hide, and it learned how to cry. There's always something in the way. There's always something getting through. It's not me, it's you. ignorance reigns true. Hope is not what I know. It's all
Oh, sorry.
I find hope when I'm let down. Not in me. It's in you. I hope to lose myself for good. I hope to find it in the end. Not in me. All I It's all I know. It's all I know. Always something always something getting through. It's not me, it's you. It's you. It's you.
So that was a brief, hold on.
So in this lecture, we're going to talk.
Zooming. Where'd you go? What do you guys see now?
Just you.
The PowerPoint?
Oh, there it goes. PowerPoint.
Okay. Okay. Oh. So ALS, also known as Lou Gehrig's disease. Lou Gehrig was a baseball player who was diagnosed with ALS. I don't know if it was exactly the prime of his playing career, but he was a Yankee, so he got a lot of attention for it. Again, a progressive neurodegenerative disorder that impacts the nerve cells of the brain and the spinal cord, and impacts their ability to move over time. And again, very progressive disorder, leading ultimately to death. ALS is where literally the neurons are dying. And so the brain's not able to move and control muscle movement. Mental status change, there are no mental status changes that result from ALS. They are fully cognitively intact and aware of what's going on. They feel everything. So again, unlike some other disorders where sensation is limited, these folks feel pain, and their autonomic systems are intact as well. This really is voluntary movements and other really impacts the decrease of the strength and movement of both voluntary and involuntary muscles. I should say voluntary muscles. Involuntary muscles tend to remain intact, which is why the cardiac systems, the GI systems tend to continue to work without any intrinsic problems. They have all the challenges of the hazards of immobility, but involuntary muscles do continue to work with ALS. And while the instinct and innovation to breathe is intact, much of the respiratory process is pegged to voluntary muscles, and those are impacted negatively with ALS. So their ability to breathe effectively is impaired. Looks like there's about 15 new cases a day diagnosed. Almost 6,000 people a year have ALS. Oh, I should say are diagnosed with ALS. And there's upwards of 30,000 people with the disease. 60% of the people are men, and the vast majority are white. ALS is typically diagnosed between the ages of 40 and 70. So it's a diagnosis in adulthood, but younger folks can be diagnosed. In terms of what the causes are, that's not been determined, but again, there is some thought that it is both a genetic and an environmental factor basis that causes the diagnosis. In terms of survival from diagnosis, that can be variable as well. Again, half of folks live at least 3 or more years, 20% live 5 years or more, and 10% of the folks will live more than 10 years. But in general, it is a life-shortening diagnosis for sure. Muscle weakness is what's seen as the first symptom that folks notice. It could be that they trip or stumble over something more often, tiredness of their arms. They drop things. Maybe they'll slur their speech. But those are some of the, and then uncontrollable periods of laughing or crying are some of the early signs or symptoms of ALS. Hands and feet tend to get impacted first, which is why dropping things or tripping or stumbling are some of the most early signs, but that weakening and paralysis continues over time, moving from the hands to the trunk. And again, over time, speech, swallowing, and breathing become impacted as well. Respiratory failure is the biggest risk to folks with ALS when their muscles are so weak they can no longer breathe independently. And so many of these folks, if they so choose, require artificial airway and mechanical ventilation. In fact, when I graduated and first got my RN, my mother was doing a home care case with a intubated, ventilated at-home patient with ALS. And that was my first private duty case. I would pick up shifts with that gal. Her husband was a trucker. He had phenomenal insurance. Everything was paid for, including around-the-clock nursing care for his wife at home. It was remarkable. Again, motor neurons, that means sight, touch, hearing, taste, smell are not affected. Unfortunately, they can't swallow, so taste becomes a bit of a moot point. Eyes are typically not affected, and bladder's typically not affected either. The mobility, again, of getting to the bathroom, positioning oneself and things like that are difficult. The vast majority of cases fall into the sporadic category. There is a small group of folks where there's a genetic component, but again, that's viewed as less than 10%. And then in Guam, there's a very high incidence of ALS, which again is another small component of the folks who have been diagnosed. Again, like so many of these diagnoses, they are diagnoses of exclusion because there's no specific test or procedure that confirms diagnosis. And so it's a matter of ruling out a lot of other stuff, doing other tests to see if it's consistent with ALS, but no necessarily one test is definitive for a diagnosis of ALS. EMGs, nerve conduction tests are important. Some blood and urine studies looking for serum proteins, thyroid and parathyroid hormone levels, looking for 24-hour urine collection to rule out heavy metal poisoning, a lumbar puncture again to rule out other diagnoses, MRIs, myelograms, nerve biopsies, and then a real head-to-toe thorough neuro exam. Riluzole is the first medicine that was approved in the 90s to treat ALS. It's an anti-glutamate drug, and it's been shown to prolong life. Persons with ALS for a few months. It's been shown to slow the progress of ALS, let those people maintain function for slightly longer periods of time. And again, over time, the result of ALS is quadriplegia. No damage to the spinal cord per se, but overwhelming muscle weakness and atrophy result in essentially the same thing, quadriplegia. And again, the real downward spiral is when the respiratory muscles are impacted. Fatigue especially while talking, muscle weakness, tongue atrophy, dysphagia, weakness of your upper extremities, fasciculations of the face, again, change in speech tone. There's a nasal quality initially, dysarthria, all sorts of voluntary muscle weaknesses are seen. Right now, except for the Rizulone, trouble with that one too. It's really supportive care that's offered patients with ALS. You have to assess them for respiratory decline, assess them for problems with immobility, and provide support to the patients and the families. But there really has not been an overwhelming breakthrough in the cure of ALS patients. Has anybody worked with someone with ALS or know of a family?
I worked with an ALS patient.
Tiffany, tell me about that, please.
Well, I think you did a great job describing it. When I was first introduced to the patient, the way that my preceptor explained it to me was basically that the patient's brain was working completely fine, but he was essentially trapped in his own body. And I thought that that was a perfect way to describe it. Yep. Because when I saw him, that's exactly what I noticed. He was able to like track me and follow me with his eyes, but he was just completely contracted all the time. So it made things like moving very difficult. And just as you described, everything was the case with him. He ended up moving to comfort measures only because of his breathing. Mm-hmm. He was unable to really carry on with his breathing. So that was kind of the reason for that. And then his family actually decided to make him DNI. So that was kind of the solution for him.
Right. It's, when you get to that point, it's really scary because again, these aren't, how old was he, Tiff?
I think he was around like 67.
So again, I'm going to go with young gentleman.
Yes, young.
And fully intact neurologically, cognitively, who has to make this decision. Do you want to live tethered to a breathing machine, knowing you can't move and your mobility is forever already grossly limited?
Right. I think he was lucky though, because his wife was like his biggest advocate, and she really was able to make sure that the care he was receiving was adequate. And because he wasn't able to speak, she was just constantly with him. So I don't know if everyone has that level of support, but he was lucky to have that.
Yeah. Well, that good for her. That's clearly probably very helpful to him in the long run.
Very scary too, because she was asking so many questions. Why are you doing that? What about this? Why are you doing that?
Just what a student loves. It's bad enough your preceptor's already always dogging you with questions. Exactly what you need for the family member to pile on, right?
Right.
But it's still a very that's. And again, this probably wasn't an emergent situation. The clinicians were trying to be thoughtful and plan ahead. And I mean thoughtful in a plan ahead perspective, not thoughtful in terms of being kind and supportive, although you end up being that as well. But you don't wait until they respiratory arrest when it's much more of an emergency per se, and it doesn't make the decision any easier per se. Hopefully, he and his wife had talked about this when they still could talk. But doesn't that show? Give it. I've often said, you've heard me say. I hope you remember me saying, someone's advance directive should act as your voice when you're no longer able to speak for yourself. And who you choose to be your healthcare agent should speak in your voice, not their voice for you. And that sounds like that was a perfect example of that, Tiffany. Would you say? Yeah, that's scary.
Yeah, I also met that patient with the ALS that Tiffany had.
Yeah.
And then I came back the next day, and the nurse that was like giving handoff report was saying that like around midnight when all the family was there, they took the oxygen off, and he like passed within like 3 minutes. And then it was like, I just thought it was really crazy because by the time we got in there at 7 a.m., there was like a new admission that had been there for 4 hours. So it's just like such a fast turnaround of like the room and everything.
Yeah. Well, that's and that's where the competing, the hospital has its responsibilities to community, to the emergency department staff, etc. You need to protect the family who's just had a tragic loss, give them time. This was recently, so you're still competing in the age of COVID, where I think most hospitals have loosened their visitor restrictions, but it's certainly not back to pre-COVID situation yet. So it's the competition and the factors that influence decision making only gets more complicated. I think is the best comment there.
I had a guy on 6-3 in the spring who also had ALS.
Yes.
I don't know if you remember him, but he was like very proud and like happy that he was like, it was like really hard to understand him, but he was like, kept saying that he has the disease that everyone says like kills you in 2 years. And he's on like year 5. So he was very like proud of that. And then I think he passed like a partial swallow for like pureed or thickened liquids. He was so happy.
Yep.
But he also was complaining because he said a major part of his medication regimen at home was medical marijuana, and obviously the hospital wouldn't let him like utilize that on the floor.
That's I don't remember that part of the conversation. I remember the gentleman. I don't remember that part of the conversation though. But I mean, I can certainly understand, and perhaps not lighting up a doobie in the hospital. We frown upon fire and things like that. But a few, gummy bears would not be amiss, I suspect. We should probably add that to the content. I know we did it as an assignment last spring in terms of medical marijuana. It's an impact, but it's certainly is an increasing. Did you talk about that in pharmacology much? The use of medical marijuana?
Yeah, there was like an article or assignment or two where we had to fill stuff out about it. Yeah, I think so.
Yeah. Okay. But again, ALS, not uncommon, essentially fatal, respiratory failure and ventilator dependence. There's actually an interesting article, can't remember now whether it was New York Times or The Atlantic, but a gentleman who diagnosed with ALS and wanted to donate his organs before organs became too debilitated with too many medicines and things like that. and the feeling, that delicate balance between euthanasia and a natural death came to play in that article. So check that out in your spare time. So now again, moving into another neurological disorder, Guillain-Barré syndrome. This is a kicker too. Just when you thought you avoided all this other stuff, Guillain-Barré is a disorder that impacts your immune system, and it disables your peripheral nervous system. And it usually is a post-viral, post-bacterial infection syndrome. What happens is patient gets an infection, the body's sort of fighting off the infection, doing its thing, but the immune system doesn't know when to stop. It goes into hyperdrive, and not only is fighting the infection, but starts destroying the myelin sheath of the peripheral nervous system. Does that sound familiar to anything else we've talked about today?
MS, but MS is anywhere and not just peripheral.
Yeah. The other thing is that, again, for some reason, the myelin that's destroyed by Guillain-Barré can regenerate. In MS, it never regenerates. So if we can support you through the Guillain-Barré, you can come back from it. And it can happen to anybody, any age. It happens to children as well as adults, men, women. There's no difference in incidence. It's a relatively rare syndrome. Again, only one person in 100,000, but it's crazy. It can happen weeks or days after some other viral infection, respiratory or GI infection most commonly, or post-operatively, or after a vaccination as well can trigger Guillain-Barré. So it starts with a tingling sensation, weakness in the legs, and then it spreads up to the arms and the upper body. Can take, some people it takes weeks for the disease to progress, and other people it's hours. So there's a huge variable perspective with GBS. And again, how long it lasts can be significant. They may peak at week 3, but it can take a long time to recover from that peak also. So again, the patient is suffering from essentially a paralysis in this post-infection, post-viral situation. And like with all other situations with paralysis, respiratory dysfunction, respiratory failure is one of the biggest concerns. Most patients with Guillain-Barré do require mechanical ventilation to support them through the period of weakness. They also have potential for abnormal heart rhythms, additional infections, all the hazards of immobility like blood clots. Can either be hypertensive or hypotensive. That's not consistent finding. And again, with the right supportive care, with good assessment, trying to nip different symptoms in the bud, people can come out the other end and, as I say, live to tell about it. But many folks, especially those with very severe paralysis for prolonged periods of time, have significant, can have disabilities long term, never necessarily recover back to their baseline. It's possible, but it's also possible that they will not get back to their baseline. So again, you have a regular straightforward respiratory or GI viral infection. You're doing your thing, and all of a sudden you've got a little numbness, a little tingling, a little weakness in your legs, and could be within hours you're fully paralyzed, requiring ventilator, and for the next few weeks. They call it a syndrome because not exactly sure what's going on there. Again, somewhat perceived as the immune system in hyper overdrive as it's trying to recover or fight off the other viral infection, or the initial viral infection. Lots of different symptoms, presents in somewhat different ways, but that overwhelming weakness, paralysis, and ultimately respiratory failure is what are sort of the hallmarks of Guillain-Barré syndrome. It can be unilateral, can start unilaterally and move to bilateral. Again, starts oftentimes in lower extremities, moving up to the core trunk area, and can move whether it's hours or days or even weeks. Can be very fast moving or very slow moving. Nerve conduction tests are important in the diagnosis of Guillain-Barré. Reflexes decline. A lumbar puncture. They see an increase of protein in the CSF when they complete a lumbar puncture. Again, supportive care, plasma exchanges, also known as plasmapheresis, high dose immunoglobulins, IVIG, have been shown to be effective. Steroids on occasion have been shown to be effective. Plasma exchange, again, this is one of those interesting treatments with a machine somewhat similar to a dialysis machine. Blood is removed from the body. So again, they're putting in that sort of temporary access like a Quinton cath. They, again, because of the way the disease moves, they certainly don't have time for an AV fistula or anything like that to mature. So they'll put in a Quinton cath. They remove the blood from the body. It goes through the machine. They separate out the plasma and other, the blood cells are returned. Minus the plasma, the blood recreates plasma, but it seems to reduce the severity and how long the episode lasts. The thought is that the plasma is containing different elements of the immune system that's attacking the myelin. immunoglobulins, again, trying to, while the immune system is there to attack infection-like things, the immune system, they believe, is going into hyperdrive. These immunoglobulins may help reorient the immune system so that it stops self-attacking, if you will. Again, not really sure why this works, but it has been shown to be effective in many cases. Again, my experience is where there are immunoglobulins, there are steroids usually being used. The steroids have not proven to be as effective as the immunoglobulins, but in my experience, they're still using steroids with Guillain-Barré patients. And again, supportive care, supporting them through the period of respiratory failure while the muscles are so weak is really the most important supportive treatment. And then making sure no other complications develop, no pneumonias, no blood clots, keep skin intact, keep feeding the patients so they've got the energy to fight what's going on, to keep their skin intact, to keep the GI tract moving, and to prevent those sorts of infections as well. So again, what starts as maybe a tingling and a weakness, tingling being paresthesia, weakness of the lower extremities, moving their way up to upper extremities into the face. Watch for respiratory failure, do a thorough respiratory assessment, assess for cardiac dysrhythmias. CSF has that elevated protein, but your EEG will be normal. And again, these patients are cognitively intact. They are aware of what's going on, which has to be, like ALS, some of the most frightening scenarios you can imagine. I think we talked about all of this, and again, in terms of supporting the patient and the family psychosocially as well. All right. We are done with the new content for today. I have a, what do I have? I have a case study I want to do with you guys.
Okay.
So why don't we take a break? Why doesn't everybody come back at 12:15? We'll work our way through the case study, and then we'll be done for the day. How's that sound? Fly to me and say fabulous.
Fabulous.
Beautiful.
Fabulous.
Thanks, Kev. Thanks, Jack. All right, I'll see you guys in about 15 minutes, 12:15, okay?
Okay.
Thank you.
Okay.
Sounds good.
Hi, Eugene. Hi, Sarah.
Did you want to stop recording, Carol Ann?
And we're going to do a case study on multiple sclerosis. So here's our scenario. Oh, before we get started, I just sent an article. Don't do that now. What are you doing? Go back. Hold on, I broke my case study. I just sent through an article. It was in the Stanford Advocate, but all sorts of information I didn't know about Jackie Robinson, and more importantly, Jackie Robinson's wife. Why'd you do that again? For the love of God, stop. I may need to do this like this for now. So we have a 32-year-old man. He's admitted to a medical floor from the neurology clinic. He's got symptoms of multiple sclerosis. He's experienced increasing urinary frequency and urgency over the past 2 months. His female partner was treated for a sexually transmitted infection. DV underwent the same treatment, but the symptoms did not resolve. He's had 2 episodes of eye fuzziness associated with diplopia and flashes of brightness. He has ascending numbness and weakness of the right arm with the inability to hold objects over the past few days. And he reports rapidly progressing weakness in his legs with blurred and patchy vision. All right. So if MS is associated with scattered, patchy demyelinization of the central nervous system, what does myelin do? What do we need myelin to do?
It speeds the nerve signals along.
It speeds the nerve systems along. Very good. And what is causing the demyelinization in MS?
Autoimmune response. So your own body is attacking the myelin, thinking it's a foreign invader.
Autoimmune and inflammation. And so the myelin sort of spreads away from the nerves, and you get interrupted nerve conduction, nerve transmission, if you will. Good job. So we said that MS is characterized by remissions and exacerbations. What changes during a remission versus an exacerbation?
Is it the activity on the activity of your body, like actually attacking the myelin sheath?
So the inflammation can recur, and we know you said activity. What kind of activity did you mean?
Autoimmune? I don't know.
Well, no, that's okay. So what did I say? I did most of the talking, but I'll use the royal we if it's okay with you all. What did we say is really important to managing MS? What do MS patients really need to do?
Rest.
There you go. Rest. Anything else they need to do?
Mitigate stress.
Navigate stress. Very good. So at points in time when they get stressed, when they get fatigued, what do you think happens to the myelin at that point? Go back to what I think it was Katie that said it earlier.
It gets deteriorated faster.
It deteriorates faster, that's right. And that's when symptoms show up. They seem more severe. It seems like the disease is progressing. And I did say that one of the differences between MS and Guillain-Barré is the myelin regenerates in Guillain-Barré. It can regenerate with MS, but it never usually goes back to full baseline. But that's the difference between a remission and an exacerbation. Does that make sense?
Mm-hmm.
Yeah.
What do you think about DV being a 32-year-old? How's that look age-wise?
It's normal. I mean, you could be as young as in your 20s.
That's right.
But it's worse when you're older.
And do we know what the etiology of MS is?
Not 100%, but they say it's a genetic predisposition that's affected by like a virus. I think there's a lot of evidence about like Epstein-Barr virus and its association with MS.
And certainly Epstein-Barr-like viruses, if not EBV itself. It's true. This case study gave a little more information. It's more common in cold, temperate climates. But again, exactly, and it's more women. Women are affected more often than men.
But men get it way worse.
Typically, yes. All right, so now I'm going to go back a slide, back to his presenting symptoms, and I want you to make a list. I'll give you like 2 minutes to make a list of subjective symptoms and objective symptoms of MS. And was there anything missing that you would want to follow up and ask the patient about, things that might be typically found with MS that weren't discussed in this presentation. So read through that, make a list, and then we'll talk about it. Subjective, objective, and what do you want to ask questions about? Okay. So what are some of the subjective signs and symptoms discussed in the presentation?
Fuzziness, progressive weakness.
What was the first one? Oh, fuzzy?
Fuzziness, like the eye fuzziness.
Eye fuzziness, yep. Progressive weakness.
Blurred, patchy vision.
Blurred vision. There's, how about numbness of the extremities? And
Caroline, would that be subjective or could that be both subjective and objective because it can be tested?
well, in this case, it's subjective because the
Okay.
patient's telling us about it.
Okay.
I mean, you could say the same thing about the weakness as well. That can be, you know, when you're doing squeeze my fingers and pushing against things, but you at this point they're still that's what the patient's reporting. And again, the patient's description of the his urinary dysfunction is also typical in MS also. Objective wise,
Urinary frequency,
urinary frequency,
inability to hold objects,
yep,
Unsteady gait.
yep, unsteady gait. Good. The other thing I didn't mention, and I should have, is MS patients typically have a terrible time with heat. They're very heat intolerant, so they don't do well in during the summer. They often need air conditioning to for both comfort and to remain stable. And I should have mentioned that because that's a common finding also. So again, when we're doing an objective assessment of this gentleman, we're going to watch his gait. We're going to see if there's any tremors. Check reflexes. Again, you know me, I'm not a big fan of nurses, bedside nurses checking reflexes, but somebody better check his reflexes. And then also his gag and swallow reflex as well should be assessed. Right? Does that sound reasonable?
Yes.
Yes.
Good. Beautiful. Okay. So how are they going to determine the MS diagnosis? Is there a definitive test?
No, but you could do like an autoimmune panel probably. But you have to get an MRI.
MRI, check for some autoimmune stuff. Those EMGs and nerve conduction tests. And like many of these neuro things, because there's no one definitive test, you do a lot of ruling out. See what comes back positive and what comes back negative, sort of thing.
I think also the layer, I forget the L word sign. That's also like something that's
you're right.
used to diagnose.
Very good. We go back in the PowerPoint for that L word. You're right.
Lermit's sign.
Metz sign. Thank you. And what does the MRI? Why does MRI play an important role in MS?
See if there's changes in the electrical activity.
MRI is not electrical conductivity.
To see how much demyelination is there?
You can actually see it, that's how precise MRIs are. You can see the size of the sheaths. Are there any lesions or plaques on the myelin sheaths? That's how fine a view your MRIs can provide these days. All right. So, and what's our goal of care with the patient with MS? Is there a cure?
Nope.
No.
Rest.
So we want them to rest.
You treat the symptoms?
Rest with an intervention. So what's our goal?
Conserve energy, safety, promote regular activity and elimination, avoid stress and fatigue.
So I'm going to go a step higher, Linda, and I think I heard Kevin's voice. We want to minimize disease progress and provide symptom relief as much as possible. Now, once we've got those overarching high goals, we're going to make sure that they rest, don't suffer from fatigue. What else did you say, Linda? You had a nice list there.
Said encourage regular exercise,
Yep.
encourage regular elimination,
Yep.
focus on safety related to sensory and gait.
Good.
We need to see if they would need any devices, assistive devices.
Assistant devices for safety purposes. And so when we're talking safety and what's another thing we're concerned about with, especially with patients with these sort of debilitating diagnoses? What do we want to promote while we're promoting safety?
Independence.
Good answer. Thank you. Good job. And how do we treat MS?
There's some therapies, pharmacological therapies, but mainly it's managing symptoms.
Very good. And so we want to, and what symptoms can we help support with medication?
Fatigue.
Well, fatigue, we want rest, and there are some medicines that can help mitigate fatigue.
The spasticity and tremors.
Spasticity and tremors, very good.
Pain.
Manage pain.
Bowel and bladder dysfunction.
Bowel, very good. And then there's another big one that comes with this sort of, if you will, terminal diagnosis and life-altering diagnosis.
Depression.
Psychological.
There you go. God, you guys are good.
Do they ever have concerns with like dysphagia? Because I know that there is like swallowing, like, I don't know, issues, but I don't know if it's something that becomes an actual issue. I know they have like problem sometimes swallowing, but I don't know if it's like debilitating.
You know, I know it certainly is with many of the other neurological diagnoses we talked about, but I'm going to need to look that one up. You know, my instinct says yes, but I'm not 100%.
Yeah, if anything, that would probably be like really late in the progression of the disease.
Or during an exacerbation.
Yeah. Mm-hmm.
Yep. All right, so the patient's ordered 500 milligrams of methylprednisolone or solumedrol. Has anyone had an opportunity to administer solumedrol in particular intravenously?
Yeah, I did.
So James, anything you remember remarkable about how it was provided to you?
I've done so many drugs these last few weeks. Is this one of the ones where I had to mix it?
Yes.
Multiple containers, and I had to use each container?
No, not usually. So solumedrol usually comes in a glass vial, but it's different from some other vials. Think your insulins or your heparins if you're drawing those up. It usually comes in two parts. The bottom is the powder, the solumedrol methylprednisolone, if you will. Then there's a rubber stopper that you can't get at. And in the top part, again, it almost looks like an egg timer. There's some fluid up there. And then there's the top, once you take the plastic off, when you push down on the plunger of this vial, it pushes the rubber stopper that separates the two parts of the vial. It pushes the rubber stopper into the powder and the fluid goes in. And then you mix it up and draw it out like that. The reason solumedrol comes like that is because if you look here on this label from solumedrol, you need to reconstitute with not only sterile water, but sterile water with benzyl alcohol. So the fluid in the top of the vial is water laced with the benzyl alcohol. So it comes in one package. You push the plunger, brings the powder and the fluid together. You roll it, because remember, you never shake to mix an IV that you're diluting. You roll it, it dissolves, and then you draw it up out of the vial.
Are those also offered in IM injection? Because my mom has MS, so when she was first diagnosed, she would have to give herself a shot every other day, and it sounds very similar to this. So I wasn't sure if.
You know, part of my problem is that I've only worked in hospitals, so we have ready IV access, if you know what I mean. We don't have to give, unless it's meant to be given IM or sub-Q, we don't have to, because we've got IV access. So it's definitely possible out in the community, but I don't know for sure.
Yeah, because then after she was doing that, they finally had come out with a pill that she could take. So now she's on actual, daily medicine,
by mouth medication, which I'm sure she appreciates compared to
100%,
yeah.
Caroline, I actually gave this last week.
Yeah.
I remember I looked it up and I remember being like, what the hell is this thing? Having to figure it out. But I remember giving it to my patient, but he had get like a small bowel obstruction from a Crohn's flare up, but
So, where there is autoimmune, there are stored steroids. You'll probably hear me say that in your head 20 years from now, unless they find some other source. But yeah, you have a Crohn's flare, you're going to add little steroids, and there you are. There's your Solumedrol. But that isn't the vial's a little different. You got to push it down. It comes with the diluent there in the top of the egg timer, and and the reason is because the water is already mixed with the necessary alcohol, and I assume that's got something to do with the pH or some activating thing. I don't know. So again, let's read the label, which you can't do the way I've got this. How is this possible? Okay. So I don't know if you guys can see that label, but you're going to reconstitute with bacteriostatic water for injection with benzyl alcohol. You are going to so when you're looking at the how do we administer this injection, and of those multiple choices, which of those do you think you would administer this safely?
What was the ordered dosage?
500 milligrams.
B's probably right.
That's a good one, Jonathan. Yep. So this was a tough one for me because the other thing, according to the, again, the answer book, if you will, is, and I will post both the answer book like I did last week, is they say steroids are best administered before 9 a.m. because if you administer before 9 a.m., it reduces the suppression of adrenocortical activity. I've not heard that before, and it's not, as far as I know, standard practice in pharmacies, but I note it here because it's in the answer key, if you will. The other thing is 500 milligrams is a relatively large dose of Solumedrol, and that should be given IV piggyback over 30 minutes. I don't know what IV pulse administration is, but it should be given piggyback via pump, if you will. Smaller doses of IV steroids, like under 250 milligrams, are able to be given IV push. But the really important thing, part of this question is, again, that Solumedrol comes with its own diluent, that you can't just use sterile saline or sterile water. You need to use the diluent that comes with it. So because the patient's experiencing urinary frequency and urgency, The neurologist orders oxybutynin, 30 milligrams daily. What else do you need to teach the patient in terms of controlling their urinary symptoms? Is there anything else we can provide to the patient? Think urgency and frequency. How do we help mitigate those things?
If you put them on a schedule, specific times to void.
Yep. That helps with the urgency, if you will. Empty your bladder on a regular basis, then you're not running to a bathroom. What else?
Leave a urinal on their bedside or within arm's reach.
That's good while they're in the hospital. So what do we do out in the community? How can we help a 32-year-old guy who probably doesn't want to run around with a urinal? So is there anything diet-wise that sort of stimulates?
Monitoring your fluid intake.
Right, and so if you want to get a good night's rest,
don't drink before you go to bed. Like, don't drink any fluids before bed.
Yeah. So have a good hearty fluid binge with dinner, but then cut off your fluids. Is there, and again, in terms of diet wise, anything that promotes urination that we can?
Caffeine and alcohol.
Caffeine and alcohol, right. So limit those two things. All right, when you're planning his care, what's the most appropriate goal for the problem of activity intolerance related to muscle weakness? And why don't you put that in chat so we can see? Looks like everybody's liking C, that DV will participate in daily activities as desired without fatigue. Those others are important aspects also, but maintaining muscle strength, again, he's got a debilitating disease that might not be feasible and might potentially be an unrealistic goal. On some level, identifying 3 factors that aggravate weakness is a good education goal, but it doesn't really mitigate his activity intolerance. And free of trauma related to muscle weakness, again, an important goal, but not for the activity intolerance, if you will. So I agree, C was the best choice. Right, so as part of your teaching plan, you want DV to be aware of situations or factors that are known to exacerbate symptoms. What things exacerbate MS symptoms?
Stress.
Stress.
Fatigue.
Fatigue.
Excessive heat.
Excessive heat. Actually, excessive cold also, sort of both of those opposite ends of the temperature spectrum. And then another, we talked about stress. So if there's emotional stress, what's the other sort of stress on the body?
Physical stress of not being able to move properly.
Physical stress, or how about physiologic stress, James?
Yeah, that's better.
Infections, things like that are gonna that will undermine someone's health and energy reserves, if you will. All right. So after testing is complete, DV is diagnosed with MS. He confides in you that he has been depressed since his parents' divorce and the onset of these symptoms. He tells you that he knows his girlfriend has been unfaithful, but he's afraid of being alone. He is afraid to tell her about his MS diagnosis, that she will leave him. So that's an unfortunate scenario. What are you going to do about that?
Get a psych consult.
Certainly have it looked into. Start with, combination of psych and social work, perhaps. Yep. How, when he's telling you this, is there any words that come to, anything you specifically want to say to him?
Just get him to elaborate more by asking questions about, like what makes him feel this way specifically.
I think it's fair to say that it's not always easy to share those sorts of fears. And so to encourage them, to thank them for being honest, thank them for being brave to say that, to acknowledge that they were brave enough to say that, means they're probably brave enough to envision something different for themselves, and that they've got the strength to continue. Because as the first step in making something better is acknowledging an issue. And you want a patient to continue to share that sort of information. You don't want to shut that down, for sure. And as Jonathan said, making sure you bring in psych and social work to offer a further assessment as well is really important. Right, so you're concerned with his psychological status, particularly the negative feelings he expresses regarding himself and the concerns he has voiced. How could you phrase a nursing outcome addressing this issue and identify independent nursing activities that you might implement? So what might be an outcome or a goal you want to see for this patient?
Maybe he can identify some strengths he has.
Very good. Strengths or coping mechanisms that he can utilize. Beautiful. And then what are you going to do from a nursing perspective along these lines? Or to support this patient, I should say.
maybe try to ask him or prompt him to do it so that.
Yep. Make time for the continued discussion, continued conversation, create an open and accepting environment. That's right, Jonathan. Continuing to let him problem solve, identify other strengths and resources. And again, support groups, offer those referrals, offer those contacts. I hate to say it's, when things get the worst, maybe they'll eventually take advantage of it, but hopefully it's not a last ditch effort, a last ditch intervention, because it can be so helpful to some folks. All right, so in view of his personal history and current diagnosis, what 2 critical psychosocial issues require monitoring in his follow-up visits? Given what he's already said, what are we concerned about?
Like depression?
Depression.
Self-harm?
And what can depression lead to?
Suicidal ideation?
Yep. And again, it's sometimes hard to ask those questions, but like I said, there are some questions we don't use euphemisms. We don't beat around the bush, if you will. We want them to understand exactly what we're asking, for sure. Community resources, local chapter of the MS organization, community therapists, social workers. Does he have a religious affiliation, his pastor? And then here's the outcome of the study, of the case study. So he takes advantage of his time with a nurse specialist, joins a local MS support group, tells his girlfriend to beat it, and he marries a woman from his support group. Talk about happily ever after, right? All right, so I will, as I said, I will post this case study. I used to have a Guillain-Barré case study also. I could not find it.